Alrighty, so today we are going to do a review of the maternal health portion of the NCLEX exam. We're going to cover women's reproductive health, pregnancy, including assessments, complications, medications. We're also going to talk about labor and delivery, again, including all of the nursing assessments and complications, postpartum nursing, and newborn nursing. So again, this is a little bit of a disclaimer. Again, this is an overview of what is covered in review books. These are notes that I myself took while I was studying to take my next generation NCLEX back in May of 2023. Again, it's a really great refresher on topics that are likely to be tested on, and to really have a moment with yourself where you can say, okay, this is what I remember from nursing school. This is what I need to review. Maybe I want my practice questions to focus on X, Y, and Z. Speaking of which, practice questions are an absolute must. This is going to help you with the exam, essentially. So this review is content-based. So it gives you an overview of the content so that you have a little bit of fundamental knowledge that you can use to go apply when you do practice questions. You should be aiming to do about 75 to 100 practice questions per day when preparing for your exam, kind of that 6 to 8 weeks after graduation. You've got your exam scheduled, you've got some time to sit down and do practice questions. And as always, please review the rationales. That is where the learning does happen. So without further ado, let's go ahead and get started. This is just a brief intro to women's reproductive health, a little bit of an anatomy review. So obviously we've got the corpus luteum. This really helps us support the uterus. And as always, the uterus is kind of what surrounds and protects and holds the baby while it grows. Okay, so after the egg is implanted, it does secrete HCG, and this helps our placenta develop. So I drew a little placenta for you guys. The placenta is going to provide oxygen, nutrients to the baby. We also have the umbilical cord. Think of it like Mickey Mouse. Okay, we've got 2 arteries and 1 vein surrounded by protective jelly. This is really important because after delivery, we want to assess the health of the umbilical cord. We really want to make sure it's got those 2 arteries and that 1 vein. We also have this amniotic sac that surrounds and protects the embryo. When you think amnion, that is inner lining. The chorion is the outer lining. Alrighty, so most of our complications with women's health pre-pregnancy include STIs and some other issues such as infertility. We've got vaginal infections, endometriosis, cervical cancer, breast cancer, and menopause. Usually our infertility is linked to an untreated STI. This is why it's really important that we do kind of a full workup. It's very important we as nurses provide education on proper hygiene to prevent vaginal infections. This includes kind of not staying in sitting water, wearing cotton underwear. We're not really putting anything up there where it's not supposed to go. And then long-term antibiotic use can put someone at risk for a candida infection, a yeast infection. Endometriosis is uterine pain and bleeding, most often treated with hormones. Cervical cancer, a big risk factor, includes HPV. These patients will have abnormal spotting, bleeding, and pain. And then breast cancer is very important that we teach women to get a mammogram every 1 to 2 years after they turn 40. If your patient has a mastectomy, we're wanting to make sure that we are not doing any needle sticks, blood pressure checks in that arm, and they should have like a limb alert wristband on that arm. Menopause kind of occurs usually in women kind of around 40 and up. They will experience hot flashes. Also, their bone density does increase, so we want to provide education on how to keep their bones strong and healthy. This includes participating in weight-bearing activities and making sure your diet has lots of vitamin D and calcium. This can also be treated with hormone therapy. Up next, we have STIs. Really, there's 6 very common STIs. I would recommend kind of knowing just a little bit about each of them, and kind of how we're treating it, a general gist, if you will. We're going to try to treat it with antibiotics if we can, with like chlamydia and gonorrhea. With gonorrhea, you'll have a yellowish green discharge. This is important to assess for in pregnancy because it can be passed to the baby through delivery. If that's the case, we're going to give azithromycin eye drops to the newborn after delivery. Syphilis has 3 different stages. It starts with a sore, then they can get this rash and flu-like symptoms. And then if it continues to progress, we'll actually see neurosyphilis. They start to have some neurological and cardiac dysfunction. Alrighty, our big kind of takeaway is that if STIs do remain untreated, they can progress to PID. This can cause infertility, ectopic pregnancy, lots and lots of pain. These patients can actually be hospitalized if they're unable to keep up with an antibiotic regimen for any reasons, such as maybe the antibiotics just don't work for them. Maybe they have a hard time taking care of themselves. Maybe they don't have a safe place to stay and rest while they heal. So that can often warrant hospitalization. Now we get to go into the pregnancy side of things. A lot of the pregnancy portion involves assessments, okay? So we'll see lots and lots of changes in the body. We want to teach the mom to increase her calories per day because she is not only having to support herself, but the baby. Lots and lots of different changes happening throughout the body. We've also got signs and symptoms of pregnancy. This is important. We want to know what is the difference between presumptive signs of pregnancy, probable signs of pregnancy, and positive pregnancy. So presumptive is going to be subjective. So the patient saying, I've just been feeling very, very tired. I've been sick lately. I'm lethargic. Also, absence of period. A lot of women will say, oh, I missed my period. I think I might be pregnant. Again, that's a presumptive sign, okay? It's going to be subjective, okay? Then we have our probable signs of pregnancy. These are things that we can observe. They are objective changes, but not always definitive of pregnancy. There can be issues with pregnancy tests that might read a false positive. While we do see Chadwick sign, Goodell sign, and Hager sign, those might indicate something else. So these are probable. With a probable sign of pregnancy, we want to follow up with a positive test. So what is these probable signs? We've got Hagar sign. This is uterine softening. Chadwick sign, you'll start to see bluish changes in the cervix. And then Goodell sign is that cervical softening. Okay. A lot of people ask, well, a positive pregnancy test, wouldn't that be a positive sign and symptom of pregnancy? Again, we can have false positives and other things such as medications, hormones might give us a false positive. What are our positive signs of pregnancy? That's going to be able to see and hear a fetal heart rate on the Doppler. Or we'll actually be able to hook mom up and we will see a fetal heart rate. And ultrasound is also a positive sign of pregnancy. You'll be able to see the baby. And then delivery, that's a positive sign of pregnancy. Sometimes you don't have moms that have access to healthcare or anything like that, and they might not know till it does happen, okay? Couple other things we want to keep in mind is Nigel's rule. This is how we calculate our due date. This is the first day of your last period. So if your period started on February 1st, you're going to take February 1st. You're going to subtract 3 months. This puts us at November 1st. We're going to add 7 days. That's going to be November 8th. So that year, it's going to be November 8th. That is due date. Also, we can look at fundal height. This is McDonald's rule. Basically, after 12 weeks of pregnancy, we're going to count how many centimeters the top of mom's stomach, goes, the fundus. And that's going to give us a good idea of how many weeks pregnant mom can be. Expect weight gain in the first trimester. Mom should expect to put on 1 pound per month. And then in our second and third trimester, about 1 pound per week. Okay. Our pregnancy assessments, we're going to make sure that we do an ultrasound. It's important that the patients have a full bladder for this. We also will do a non-stress test. With a non-stress test, we are looking for reactive versus non-reactive. Usually it's not done too often, but for risky pregnancies, like moms who have had multiple miscarriages, moms of advanced maternal age, babies that might have some sort of anomaly, we're going to do this more often, okay, every other week. Mom should be in semi-fowlers on her left for this. So we want a reactive NST. Reactive means that we are seeing the baby's heart rate have accelerations greater than 15 beats per minute in the heart rate in 20 minutes. So we have a 20-minute period. We want to see 2 or more accelerations. This is good. This is what we want. A non-reactive stress test is when we will not see those 2 or more accelerations greater than 15. If it progresses to 40 minutes, we need further testing, okay? When we have a non-reactive stress test, we can try to stimulate contractions by any sort of stimulation or oxytocin. Remember, contractions will cause the baby's heart rate to accelerate. We basically want to see, does the baby's heart rate react to stress? Okay. Next, we have our BPP. This is kind of a score that we use that assesses our fetal well-being. Amniocentesis is done at 14 to 16 weeks. Okay. It really helps us assess for abnormalities, specifically neural tube defects. Okay. Usually we do this early, but if you have a mom, again, of advanced maternal age or moms with risky pregnancies, they might do it again at around 32 weeks. Okay. And then finally, we have our fetal heart rate assessment. We want to see a heart rate between 110 and 160, and we want to feel the baby kick about 10 times every 2 hours. Baby starts kicking at around 16 to 20 weeks. If you have a mom that does use tobacco products or consume alcohol, this will lower the fetal heart rate and the activity of the baby. So that is something to keep in mind when we do screen moms for tobacco and alcohol use. And we'll talk about that in our newborn section in a little bit. Okay. Everyone knows our GTPAL. This helps us classify moms in labor and delivery. So obviously gravida is how many times mom has been pregnant. And then T stands for term. How many babies did she deliver that were greater than 37 weeks? My mom is a T0. She had 2 kids, both born at 32 weeks. So that is 0. Now, if you have mom that went all the way through her due date and delivered at 40 weeks, she's got 1 term. Preterm, that would be my mom. She is 2P. She has 2 preemie babies. And then A is how many abortions or miscarriages mom has had. And then L is living children. Okay. Mom can, deliver 6 babies, 6 children, but if she lost one of her children, this would lower our L. So you can have more living children than deliveries. Okay, so again, this is how we classify. Part of our prenatal care, a lot of it's going to be education-based. We're really assessing for any sort of risk factors that could cause mom to deliver earlier, to have a difficult delivery. We also want to provide as much education possible, such as healthy foods, specifically folic acid foods, what she needs to avoid, again, with the immunity infection. We'll talk about that in a few. And then really what she needs to avoid. We avoid our teratogens. These are toxic for pregnancy. These drugs include lots of our cardiac medications and psych medications, such as lithium, phenytoin, other antipsychotics. Our antibiotics, obviously, are tetracyclines, ACEs and ARBs. Again, not safe for pregnancy. Cigarettes and alcohol we know are not safe for pregnancy. And then we have our torch. Okay. And again, we'll talk a little bit more about that. So this is what mom can expect throughout her stages of pregnancy, and really what is a good checklist for mom. So in the first trimester, we really want to do blood tests, urinalysis, we want to do labs, we want to test for STIs. And again, we're going over what mom needs to avoid, what she needs to add into her diet, etc. In the first trimester, around weeks 10 to 12, we can start to Doppler at visits the fetal heart rate. In the second trimester, the mom might feel some quickening. She might feel a little bit of discomfort, a little bit of a difficulty breathing sometimes as the baby begins to settle, or might kind of push up against a certain area of the stomach. This is when we're going to do ultrasounds to assess for fetal anomalies. Mom should expect to now be gaining 1 pound per week. We want to make sure we're increasing iron. Reason folic acid is very important for diet is because it helps prevent neural tube defects. Okay, we're also going to do our diabetes screening. In our third trimester, mom's probably going to start to visit the doc every other week. And then as she progresses through the third trimester, she's going to have weekly visits. Okay. Again, we want to feel the baby kick 10 times every 2 hours. Okay. A priority concern is if mom stops feeling baby kick. Okay. And it's been about 2 hours and she hasn't felt the baby kick. That is our priority. If mom suspects her water broke and she's not sure, maybe it's early in the third trimester, they can do a nitrazine test where they test the fluid that came out of mom. And if the stick turns blue, it means that their water broke. A little word about RhoGAM shots. Again, we'll talk about this in newborn and pediatrics, but a big issue is when you have a mom who is rhesus factor negative. That means she is B negative, AB negative, O negative. It's the blood type, and then does she have rhesus factor or not? So if mom is pregnant for the second time, she's going to receive her RhoGAM shot at 28 weeks. Also, if mom delivers an Rh positive baby, it's going to be given within 3 days. Okay. It's very important we screen mom with a Coombs test to look at Rh sensitization. Essentially what happens is if mom carries an Rh positive baby, remember with our rhesus factor, if we do not have it, if we are negative, we will create antibodies to a positive. And this can lead to hemolytic disease of the newborn where mom's antibodies attack baby in utero. Okay, so it's really important that we if mom is going to try to get pregnant again or mom gets pregnant again, that we make sure that she has access to care so she can get this. Now we talk about our complications of pregnancy. Cardiovascular disease is a big issue. Mom is having to support a baby, pump extra blood. Her heart has to work extra hard. So if you already have a mom that has some cardiac issues before pregnancy, we want to make sure that she is safe. Okay, safe for mom, safe for baby. Okay. Gestational diabetes, we screen for gestational diabetes between 24 and 28 weeks. How this works is mom will ingest 50 grams of a sugary glucose drink. And if her blood glucose raises above 140, we're not going to assume gestational diabetes just yet, but this is a positive result, so it's going to warrant further testing. Then we're going to do the test again and check sugar at 1, 2, and 3 hour levels to see if it still kind of rises. Okay. A big issue with gestational diabetes is it can put the baby at risk for fetal macrosomia. A larger baby, it's going to be a little bit harder to deliver. Polyhydramnios, because the baby is so big, shoulder dystocia, and ultimately does put mom at risk for preeclampsia. Okay. I would say our priority for a priority complication of pregnancy is definitely this hypertension preeclampsia. So what is eclampsia? Eclampsia is seizures. So pregnancy-induced hypertension can cause mom to have seizures. Okay. Preeclampsia includes proteinuria. A lot of people think it's just seizure related, but with pre-E, they'll have protein in their urine. Okay. This can kind of include our HELP syndrome. This is a very, very bad complication of preeclampsia. So what exactly is HELP syndrome? It is preeclampsia that causes hemolysis, elevated liver enzymes, and low platelets. So if we see mom starts to have some high blood pressure, she notices some swelling in the legs, we're going to want to do a full rainbow set of labs on mom. We want to look at what her hemoglobin and hematocrit are. A lot of our assessments are visual. Is mom jaundiced? A lot of the jaundice just come from a little bit of the elevated liver enzymes. You're going to have increased ALT and AST. Mom's also going to have lots of abdominal pain, nausea, vomiting. And then we're also going to look at platelets. Is her platelet count low? This is our HELP syndrome. Okay. If hypertension is not treated in pregnancy, or the preeclampsia is not treated in pregnancy, it can then progress to eclampsia. That's our seizures. Okay, this is severe preeclampsia. Patients now having seizures, massive headaches. How do we treat this? We have to give mom mag sulfate, and the baby needs to be delivered. Okay, what can we do for mom who's having seizure? Place mom on left side, and she's going to be on strict bed rest. A lot of our nursing care focuses on assessing mom. Why do we need to frequently assess mom? These patients will also often be a one-to-one in labor and delivery, one nurse to one patient. For mom receiving mag sulfate, we need to make sure we're checking urinary output, we're checking our reflexes, respiratory rate, and level of consciousness. Okay, we're checking essentially for overdose of mag sulfate. So if you start to see a drop in urinary output, a drop in reflexes, drowsiness, lethargy, we need to give calcium gluconate. Whenever you have an order for mag sulfate, you should always have an order for calcium gluconate. They need to come together. If you don't, you need to call the provider and get that order. Often they'll put like a Foley in these patients so we can strictly monitor intake and output. Okay. A couple other complications of pregnancy. We have hyperemesis gravida. This is when mom is unable to keep down food, which results in weight loss. Again, we need mom to be gaining weight for the health of baby. So really, what are we going to do? We're going to make sure that we monitor fluid and electrolytes. We're replacing dry carbs and small frequent meals are most important. We can also give Zofran for these moms as well to kind of help with that in the acute phases. Next, we have abruptio placentae. Really pay attention to your assessment findings, okay? You're going to see dark red, bloody discharge. Mom's going to have a rigid board-like abdomen. This will warrant an immediate C-section, okay? Placenta has essentially ruptured, okay? Ectopic pregnancy is when the baby implants outside of the uterus. Mom is not going to be able to carry this pregnancy. They're going to have lots of pain in one side. The issue is that this can rupture and cause bleeding, which puts mom at risk for shock. What are our hallmark signs and symptoms of shock? We've got that drop in blood pressure, the compensatory increase in heart rate, and the mom can also have lots of shoulder and abdominal pain. Molar pregnancies are non-viable pregnancies. Mom will have some dark brown discharge, and on kind of more ultrasound assessment, it's grape-like clusters, okay? Placenta previa, on the other hand, is when it kind of starts to detach from the wall. So we're going to have to put mom on bed rest, and if we see this bright red bloody discharge, it's going to be painless. We're not going to want to perform any vaginal exams. We're not going to want to absolutely no sex. Obviously, we can't risk putting anything kind of into mom. Intrahepatic cholestasis. This happens when bile acids begin to build up. Mom will start to be itchy all over, so we can give some uric acid to help. Cervical insufficiency is when mom starts to have early contractions because, the cervix is just not able to properly close and support and keep baby in there. This is treated with a cerclage surgery where they actually go and they kind of sew the cervix closed. And then at 36 weeks, they're going to go ahead and remove sutures and everything like that and have baby deliver. Anemia is very common in pregnancy. Moms can often resort to pica, where they start to eat really odd items. Oligohydramnios is a decreased amount of amniotic fluid. Remember, amniotic fluid protects baby. If we don't have that fluid, it can lead to cord compression. And again, we're going to go over how we assess for cord compression. And that's going to be in our fetal heart rate monitoring. But just keep that in mind. That is a risk factor. Okay, and then lastly, we have polyhydramnios. This is too much fluid, okay? Puts mom at risk for postpartum hemorrhage, okay? If mom begins to have a drop in blood pressure, we're gonna wanna tilt her to one side. Now we get to talk about labor and delivery. We talk about our 6 Ps. We've got our psych, which is mental, emotional. We've got powers. These are contractions, okay? Our goal is to have them essentially more than 2 minutes apart. If she's having contractions like every 20 seconds, that's not healthy for baby. Baby doesn't have time to kind of rest and recuperate. We also can't let them be longer than 90 seconds. Again, baby needs to recuperate. If you have more than 5 contractions in a minute, this is uterine tach. We also want to make sure that in order for a baby to be delivered, because contractions are essentially helping push the baby down and out, the cervix needs to be dilated and effaced. Okay. We also look at passenger. How does the baby play into things? Where are they presenting? We want to ideally have them at 1, 2, and 3. Presentation for station, this means that they are below the ischial spine, that they can be delivered. If baby is still high up and are having all these contractions, it's probably going to warrant a C-section. We also want head down. When we feel the baby, we will feel a diamond shape in the head. This means they are head down. Okay. We also look at right or left. Ideally, we want baby to be presenting right occipital anterior. Okay. If baby is right occipital posterior, again, this isn't terrible for baby, but it's going to be very painful for mom. And again, we want to make sure mom and baby spines line up. We can't have mom's spine and then baby's spine kind of horizontal. You can't deliver that way. Okay. And then passageway, we look at the birth canal. So what are signs of true labor versus false labor? Well, true labor, you're going to have these regular contractions that progressively get worse. Especially, they also get worse with walking. You'll start to see some dilation and some blood. And then you'll start to see the head kind of settle into the pelvis. False labors are Braxton kicks. These are irregular, non-progressive contractions. They often lessen with physical activity, and they're not going to be dilated, no efface, no bloody show. Okay. We have our stages of labor. Stage 1 is all about the cervix. We are looking as mom in latent, active, and transition. This is how dilated is mom, how frequent are our contractions. When she is ready to deliver, she'll be essentially fully effaced, fully dilated, having these contractions every 2 to 3 minutes that last 45 to 90 seconds. Okay, it's very important that we medicate for pain prior to the transition period. This is very painful, and by the time they get there, pain medication, it's not going to have enough time to work. Okay. Stage 2 is delivery of the baby. Our priority is clearing the baby's airway. If we need to suction baby, we suction their mouth and then their nose with a bulb syringe, and we're going to do an APGAR at the 1 and 5. Stage 3 is delivery of the placenta. Once placenta is out, we want to make sure it is fully intact. It's not missing any pieces. We're also going to assess the umbilical cord, making sure you've got that 1 vein and that 2 arteries. After placenta is out, priority is going to be massaging the fundus. And then stage 4 is our recovery. This is about 2 hours after placenta delivery. Our priority is checking vital signs, making sure there's no hypotension. We're massaging the fundus, making sure that it is firm. Okay. We also look at the padding underneath mom. Is it completely saturated? If a pad gets fully saturated in less than an hour, that is a priority finding. It can indicate postpartum hemorrhage. Okay. We also look at fetal heart rate variability again, 100 to 160. If there is ever like a concern, or you might have a question and you're unsure what to do, when in doubt, check the fetal heart rate. Okay. If you start seeing a fetal heart rate that is low, if mom is on Pitocin, we hold Pitocin. Again, we'll talk more about our fetal heart rate in these next coming slides, but they talk about pit lion a lot. This is a good way to remember really what we do. No variability is bad. This means baby's heart rate is not having these accelerations and decelerations. The baby is not adapting to the contractions. It is a sign of fetal demise. So if we are having a low heart rate that is not accelerating, we've double checked the fetal heart rate. Again, we're not seeing accelerations. The first thing we're going to do is we're going to hold the Pitocin if mom is on Pitocin. The next thing we're going to do is lie mom on her left and give aggressive IV fluids and oxygen. And then finally, we notify the doctor whenever you are answering questions or you have questions, case studies, whatever, for the purpose of your exams. You will always provide interventions first, helping the patient, staying with the patient, and then notifying the provider. The first thing you're going to do is not notify the provider. We need to perform interventions first. Common medications that we use in labor and delivery, we have oxytocin, Pitocin. These stimulate contractions. Again, we don't want mom to be having too many contractions because this can lead to the low variability. So if you've got fetal bradycardia or late decels, we hold it. Okay. Methergine can be used for postpartum hemorrhage. Mag sulfate, we've already discussed, is used for preeclampsia. Remember, our antidote is calcium gluconate. Terbutaline helps slow contractions for preterm labor. So if you have mom that's at 30 weeks and she's having contractions, we can give some terbutaline. Betamethasone is given to decrease respiratory distress syndrome, helps with surfactant. If you have baby that's delivered between 24, 34 weeks, you got a premature baby, they're going to receive this. Okay, what can we do for moms that are past their due date? We can give misoprostol. This helps ripen the cervix. Methotrexate is used for ectopic pregnancies. And then penicillin G, we've talked about if you have a mom with group B streptococcus, this is going to be given prophylactically. Pain management, most common is going to be an epidural. However, we must hold it for hypotension. Remember, epidural pain medication. What do we do for lots of our pain medications? Well, before giving a pain medication, we have to check blood pressure. Usually if blood pressure is less than 100, we can't really give pain meds. So epidural, we hold for hypotension. Also, if mom is getting epidural, we're going to bolus fluids to follow. Again, we want to make sure mom doesn't have that hypotension. A pudendal block can be a anesthetic, local anesthetic injected in the perineal area. Maybe mom had a tear and needs to be sewn up. This can be given for that. What else can we as nurses do to kind of help mom and support mom? Lots of moms will benefit 8 to 10 liters of oxygen on a non-rebreather mask. Remember, nasal cannulas will not deliver really anything greater than, I believe, like 6 liters per minute. Even if you crank it all the way up, they just don't have the power to do that. So non-rebreather mask is best. Also, after mom has had her ROM, rupture of membranes, after her water has broke, we're going to limit vaginal exams. Okay. Also, if mom has some unknown bleeding, we're going to limit vaginal exams. Alrighty. What can we do to assist with labor and delivery? Amniotomies can help stimulate that rupture of membrane. Again, priority. Once mom's water has broke, we are not, that kind of helps protect the baby. So we're not going to start introducing new pathogens, stimulation into the area. Okay. Amnioinfusion can help with that oligohydramnios. Remember, we'll see variable decelerations when we start to have cord compression. So we're going to try to essentially cushion up the baby and their cord. Okay. Vacuum-assisted births, most often complication is capsucutum. We'll talk about in a few. Forceps can also help really when mom is just too tired to continue. Episiotomy happens if there's any sort of shoulder dystocia. This can often happen when you have a baby with macrosomia. Really, they have to make a surgical incision to help get baby out. And then our C-section. So some complications of labor and delivery. We've got preterm birth. Mom is going to be on bed rest. We're going to give baby betamethasone. Fetal distress, you'll start to see changes in the heart rate, maybe no variability. Again, we always do our pit line. We're going to stop the Pitocin. We're going to place mom on her side, lay her on her side, give O2 and fluids. Umbilical cord prolapse, you will see the cord come out before baby, or when you're feeling baby and you feel the cord before the baby. That's a priority finding because if the baby pushes on the cord, it can compress the cord, baby's not getting oxygen. So we're going to do whatever we can to keep the baby's head off the cord that is being squished. We can place mom and knees to chest. We can physically hold the baby up. Yeah. Amniotic fluid emboli can occur. You'll start to see a drop in O2 stats. We need to deliver the baby. Shoulder dystocia is very common. We can put the mom in McRoberts position, where she flexes her thighs to her chest. Okay. What happens with shoulder dystocia is baby's head will come out and then the rest of their body won't because their shoulder is stuck. If the baby's head comes out and the baby hasn't been delivered in less than 5 minutes, the baby can have some asphyxia. Okay. Episiotomy if necessary for this. And then uterine rupture, you'll start to see issues with the fetal heart rate, requires emergency C-section. Any sort of intrauterine fetal demise does put the mom at risk for DIC. All right. Kind of moving from labor and delivery, we've got our postpartum nursing. Our priority for postpartum nursing is assessing for postpartum hemorrhage. If you remember anything, this is what you really want to look at, okay? We do our full postpartum assessment. First thing we're gonna do is we're gonna look at the breasts. Are they kind of even? Any sort of issues? Again, we'll talk about the issues in a few slides. Uterus, is it firm or boggy? We want a nice firm uterus. If it is boggy, we need to start massaging that fundus and start some medications. Bowels, you got your bladder and bowels. We really want to encourage the patient to pee. Peeing is very important. It helps keep the uterus midline so that it can begin to shrink. Okay, if mom's bladder is completely full, it's going to throw it off midline, have a hard time, shrinking. Okay. Also look at lochia. Is mom producing lots and lots of blood? If she's having a large amount of drainage, she's soaking through padding. That's priority finding. Okay. Emotion, they talk about our postpartum blues versus postpartum depression. Postpartum blues are often in the first 10 days. Mom's just very, very fatigued. Postpartum depression, on the other hand, this continues to last and mom begins to be unable to care for herself and baby. This can also have the suicidal thoughts, which won't happen with the postpartum blues. Okay. Again, priority concern is assessing for postpartum hemorrhage. We talk a little bit about breastfeeding versus formula feeding. A lot of it is going to be education based. If you have a mom that is breastfeeding, you want her to kind of stimulate the area. Warm showers help with the pain. Massages help with the pain. Frequently feeding the baby helps. Okay. Supportive bras are good. If mom decides to formula feed, we want to basically help her not produce all of that breast milk. We want to avoid her becoming engorged. So we're going to instruct her to wear a tight fitting bra and really limit stimulation. She's going to face away from the shower because that water can provide some stimulation that could lead to lactation. Big postpartum complication is going to be our postpartum hemorrhage. Okay, lots and lots of different risk factors. Mom will completely soak through a pad in less than 15 minutes. She'll have a very foggy foggy fundus. And this is because of uterine atony. What can we do is we're going to massage the fundus, empty the bladder. A Foley catheter might be necessary. And giving some methadone or oxytocin. Okay, we already discussed our age incompatibility earlier. Infections of kind of the breast tissue can happen. If mom does have mastitis, she'll start to see some unilateral swelling. What can we do for this? Provide heat. We treat with antibiotics. We give some NSAIDs and we give some fluids. Okay. Alrighty. Nursing care of mom. As soon as she kind of delivers, we want to promote ambulation, get her up and out of bed. We want to prevent DVTs. If mom starts to feel very anxious all of a sudden, this can often be a sign that mom might be having a pulmonary embolism. Okay. We also want to make sure infection doesn't occur, but it is normal for the white blood cells to increase after birth. So just kind of keep that in mind. While preeclampsia is treated by delivering the baby, we want to closely monitor mom after birth because she can still have some eclampsia after birth. Okay, methylgovine. This is again good for postpartum hemorrhage, but if mom has hypertension, we need to hold it. Okay, always look at mom's fundus. If it's not midline, have her pee. And then really, is mom adjusting appropriately? We've got these phases after delivery. We've got our taking in, taking hold, and letting go. Okay. Right after delivery, mom's very excited. She doesn't really want to share baby with anybody. Taking hold, she's ready to start interacting with baby, interacting with others, and then letting go. They're kind of establishing kind of roles as a family. Who's going to watch baby at night? Who's going to kind of switch? Who's going to maybe take the other kids to school? Things like that. And this is really important when we're assessing for the kind of postpartum depression versus postpartum blues. And finally, newborn nursing. We look at our APGAR scores. I personally don't think it's important to fully score the baby. Just know that if they rank a 0 in a category, it means that they meet none of the criteria. 1 is going to be minimal and 2 is going to be good. Very rarely will you have a baby ever get a full 10 at delivery. But again, is the baby in good condition, moderate, or is baby distressed? We look at color, making sure they've got good color. We want their heart rate to be greater than 100. We want to be assessing their reflexes and muscle tone. And then is baby crying? Crying is a great thing that we want to hear after delivery. Okay. Couple newborn vital signs just to be familiar with. We want to avoid rectal temps after birth. It can put baby at risk for infection. We'll also look at baby's blood pressure. Heart rate is normal to elevate when crying. Okay. And yeah, avoiding specifically, we want to make sure baby pees within 24 hours of birth, and they should have about 6 to 10 wet diapers per day. It's very important we assess their poop. They must pass meconium within 24 to 48 hours. If you had a mom when she had her rupture of membranes and it was kind of a greenish brownish, we're concerned baby might have aspirated on that meconium. Okay. All right. We also are going to do more of an assessment of baby. We want to look at the baby's head. We've got our posterior fontanelles. These are going to be very, very soft. They close pretty early on. Then you have your anterior fontanelle. This closes in about 18 months. This is that diamond shape that we feel. We also assess baby for reflexes. This is very, very important. We look at their rooting. When you stroke the cheek, does the baby begin to start sucking? This helps with latching, breastfeeding, etc. We also look at their grasps. We look at their Babinski reflexes and their startle reflexes. Okay. We want to see, does baby kind of have reactivity, inactivity, and second reactivity? Second reactivity occurs when maybe you stimulate baby and baby takes a minute and then they, kind of start crying. Okay. We also assess baby skin. It's very important to know what's normal versus what is not normal. This can kind of help with our assessments, but also if you see a baby on the bottom kind of come in and they've got like this bluish, we don't want to right away assume that it's bruise, it's abuse. It can be their Mongolian spot. So it's important to document that at birth. Okay. Alrighty. Some newborn nursing care. Priority is going to be getting that APGAR score, making sure baby is warm and dry. And before that baby leaves that labor and delivery room, they must have an ID band placed. We've already discussed suctioning. Some things we give right after delivery is erythromycin eye drops and vitamin K. Also making sure mom gets Hep B vaccine. We're encouraging mom to kind of breastfeed every 2 to 3 hours, keeping baby upright. For the umbilical cord that's been cut, we're not going to try to like remove it or anything like that. We're going to use a nice neutral cleanser and keep it clean and dry. For babies that were circumcised, it's very important we change the diaper every 4 hours to prevent with infection, and we're just cleaning with water and like a petroleum jelly. Okay. It is normal to have a little bit of decreased urinary output on the first day after having a circumcision. And then we're checking baby's weight. A little bit about newborn codes and neonatal resuscitation. A lot of times with adults, obviously, you see the heart rate going down, 30s, 20s, etc. We're going to start initiating a code because that's like incompatible with life. But with babies, if we start to see heart rate dip less than 100 and they start having, difficulty breathing, obviously, first thing we're going to want to do is try to stimulate the baby. We can baby up a little bit. If they're still having some difficulty breathing, we can give PEEP, oxygen. And then if that heart rate is less than 60, we're going to start coding the baby with a heart rate less than 60 because that's going to be incompatible for survival. Okay. Just because they have a pulse doesn't mean that it's going to be able to sustain. So if baby's heart rate's less than 60, we're going to start pushing epi and starting compressions. We compress about 1 to 1.5 inches. Okay. What can we do for baby? We're going to place a towel under their shoulders to help open the airway. Remember, when you are ventilating a baby, you put them in that neutral sniffing position because they have very, very, very fragile necks. Lots of our complications of the newborn kind of surround substance abuse. So it's very important that we are screening mom early in pregnancy for any forms of substance abuse so we can give help. With babies going through withdrawal, they're going to have high-pitched, constant cry, and everything's going to be really increased. Okay. You'll also start to see baby yawning. Yawning isn't a normal finding for a newborn. If they start yawning, it can indicate baby is in withdrawal. We're not going to be giving Narcan for baby. We can give phenobarbital to help, but really a lot of it's going to be decreasing the stimulation and swaddling the baby. Okay. Fetal alcohol syndrome, these babies will have decreased growth, maybe some microcephaly, poor feeding, and thin lips. We're really going to assess for withdrawals. Withdrawals kind of happens with our neonatal abstinence syndrome. These babies have high-pitched cry, some upset, lots of GI-related issues. So we're going to want to swaddle and rock the baby. For moms that use tobacco during pregnancy, it puts baby at risk for low birth weight and sudden infant death syndrome. Bowel obstructions can occur. This is why we're making sure baby passes meconium in that first day or two, because this can indicate bowel obstruction. What can also indicate bowel obstruction is baby might have some bright green vomit. Okay. Sudden infant death syndrome does occur quite frequently, so we want to educate mom on following the ABCs. Babies should be sleeping alone in their own crib on their back. So alone on their back in the crib. And that doesn't mean just alone, not sleeping with mom. Obviously, mom baby co-sleeping is not recommended. Baby needs to be alone in their crib, but there shouldn't be any pillows, any blankets, any stuffed animals, anything like that. Completely naked bed, okay? Alrighty, onesies and pacifiers are okay. Preterm deliveries when baby is born at 20 to 38 weeks. The issue is less than 24 weeks. Their kind of alveoli haven't fully developed. They haven't developed surfactant, so they can have issues with breathing. Okay, with these preterm babies, we want to give surfactant and steroids and really decrease stimulation, allow them to grow. Post-term delivery is when baby's delivered after 42 weeks. It's going to be harder for mom to deliver. And then respiratory distress syndrome, you'll start to see an increase in respiratory rate with these babies, nasal flaring, grunting, and retractions. We can give Baracant, and this helps with the little ones. Some more complications that can occur during delivery. We've got our caput. This essentially is edema above the skull from a difficult delivery. But this will go away with time. Cephalohematoma, again, can be from a difficult delivery, and you'll start to see a little bit of collection of blood and bruising. Macrosomia, biggest risk factor for macrosomia is gestational diabetes, puts baby at risk for difficult delivery. And then hypoglycemia at birth, okay? What is hypoglycemia for a newborn? It's a blood sugar less than 40. Okay. Any issues with kind of size of the baby, if they're not just right, are at risk for hypoglycemia. But this is also why it's important we make sure we dry the baby off after delivery and keep them nice and warm. Cold stress will drop their blood sugar. Okay. We get blood sugar from babies by doing a sugar check on the side of their heel. We're not doing right down the middle. We're doing it on the side of the heel with a lancet. Symptoms of hypoglycemia in newborns include having a weak cry, baby very jittery, lethargic, sweaty, and just overall poor feeders. Okay. A cleft palate, baby with cleft palate will require a special bottle. It's important that while we're feeding, we keep the bottle facing down and away from the cleft lip. We are going to have to burp these babies more frequently and really making sure that they're upright during feeds. We're probably also going to make sure that the feeding time doesn't last too long with these babies. Not longer than 30 minutes. We want to let them have time to kind of rest because it is more difficult for them to feed. It can tire them out. Cold stress is very common. I cannot reiterate this enough. Baby needs to be kind of, when we're doing the APGAR, within the first minute, dried off. Skin to skin is good, but when we're not doing skin to skin, baby will be put in an incubator. Okay. Symptoms of cold stress, you'll start to see some increase in respiratory rate. Baby's going to be irritable and just overall a poor feeder. We avoid rectal temperatures in newborns. Again, puts baby at risk for neck. We want to avoid any sort of infections, any sort of perforations. Yes, we do rectal temperatures in like our pediatrics, but newborns, we don't. Failure to thrive can occur. This is when baby is just simply not putting on weight, not progressing. We want to get social services involved. Is it an issue of just accessibility? Does the baby maybe have an allergy to mom's breast milk? Or is there an underlying condition such as cystic fibrosis that just is hindering the baby from thriving? Okay. Neck, we've got our enterocolitis. It's very important that after birth, we are using the tape measurer, the little measurer, and we are checking our abdominal girth. If you start to see an increase in abdominal girth, this is a priority finding. What are we going to do? Make sure we keep the baby supine with no diaper and assess for perforation. Reflux can occur. Baby can spit up, have a little bit of difficult times with breathing. and kind of keeping down their food. This is why it's important after about every ounce we burp the baby. Small, frequent feeds are key. Abdominal GI deficits and issues are very, very common. We might even see some protrusion, herniating bowel, etc. Similar to if we have a baby that's kind of spine neural tube is open, we always kind of cover with sterile saline and a gauze dressing. If you have babies with GI issues, they're going to need to receive their food and electrolytes via an IV. Trisomy 18 is Edwards syndrome. Big issue with trisomy 18 is that baby will have failure to thrive. You'll start to see low birth weight, very small head. Baby will have some clenched fists. This can often be seen during the quad screen in that second trimester where we're assessing for anomalies. Hyperbilirubinemia, very common. This is a neonatal jaundice. Can occur from ABO compatibility. But this is kind of within the first 24 hours after birth. That is abnormal. It is normal for a baby after kind of 24 hours, kind of a couple days after delivery to start to develop some jaundice. Really, we treat with phototherapy, making sure that we are covering the eyes and the genitals of the baby. We're repositioning them. Essentially, when a baby is receiving phototherapy, the only time we're going to remove them from the phototherapy is if mom is feeding or doing any sort of skin to skin. And then finally, we've got our spina bifida occulta. This again can range in severity. Spina bifida occulta essentially though is the worst form of spina bifida. This is when we have an outward protrusion of the neural tube and the nerves of the spine. Okay. Very important, we make sure we keep the baby prone. We are lying them on their tummy. We are rinsing it with some sterile saline and covering with a sterile dressing. Our issue with spina bifida occulta is it puts the baby at risk for hydrocephalus. When they've kind of got increase in CSF fluid in the head, you'll start to see those bulging setting sun eyes. We will have high-pitched crying, poor feeding. What can we do for hydrocephalus? Surgeons are going to place a shunt. So we need to know how to properly care for a baby that has received a shunt. So what do we do for this? We make sure that if they place the shunt on the left side, that we are not laying baby on the left side. That can include the shunt. Okay. If there's any sort of blockage, baby will often have some projectile vomiting, irritability. They're not going to be able to be consoled. Those are our priority findings. Okay. So that is all I have for our maternal newborn review. If you have any questions, as always, let me know. And we are going to be doing a pediatric review in the next coming weeks. So thank you all for coming.